Good morning, this is Dr. Rutledge, and I'm pleased to be invited to look on during this planned presentation on reflux in bariatric surgery. I think I'm here to defend the MGB, but hopefully we'll talk about a lot of other things besides that. I'd like to open by sharing my screen for a few slides before we start the presentation. So I'm going to go ahead and share the screen. And I'll mute myself visually here. And so reflux, we're going to talk about why it happens, how to prevent it both at surgery and how to resolve it post-operatively in individual patients. And we'll look at, as I say, the causes and the treatment. And we might mention slightly lifestyle prevention and treatment. I hope so. And so this is Arnold Schwarzenegger in the Terminator movie, Come With Me If You Want to Live. And so today we reach out our hands to you as the presenters. Come with us if you want to not have GERD. Mini gastric bypass is part of the discussion today. And we'd like to say our opinion is that when you understand it well, you can perform it with great success and safety. If there is any questions, I volunteer to talk to you about the MGB and some of the opinions that I have. I'd like to start off also by saying that the reason I'm here today is that Dr. Kular and Dr. Magenda basically kept me safe during the pandemic for a year in India. So they deserve quite a vote of thanks. Can you imagine putting up with me for a year? So Dr. Kular, Dr. Magenda, thank you very much. And I'm also thanking my new partner in Tijuana, Dr. Ilal, who has invited me to be part of his program here. I also like to honor Dr. Harris Khwaja for creating the IBC and having these seminars, which are reaching all around the world. And so congratulations and thanks to all of you and the team that supports the IBC. We're going to be talking about the MGB paradox a little bit in that some surgeons, including myself, have reported very good results, but there are others reporting bad results, such as poor weight loss, excessive weight loss, bile reflux, even leaks and death. And so we see that as something of a paradox, and we hope that maybe, including gastroesophageal reflux disease, we might be able to tease out some of the explanations between these different opinions and reported outcomes. A reminder, the MGB is not something clever that I invented. It's just a routine general surgery that I've been doing for a long time before I did anything called an MGB. It's just a Billroth 2. And so our hypothesis, one of the features of today's talk is if you're seeing a lot of reflux, we know the Billroth 2 in itself does have some, but if you're seeing a lot of it, maybe it has something to do with you. The MGB done wrong, technical errors leading to reflux is something we'll talk about. And our objectives today then are to maybe tell you something you don't know, tell you something new, clear up maybe some things that are confusing, and maybe tell you something that you think you know is wrong. Reminder again, the MGB is nothing special. It's just a Billroth 2. And one of the things that we've seen are complications that can cause reflux, marginal ulcer, and perforation. And so we've seen things like the twisted gastric pouch, placing an anterior gastrojejunectomy, which can lead or facilitate twisting, creation of a bird's beak pouch, and devascularized gastrojejunectomy anastomosis. We've also seen ischemia. So depending on where you place the stapler, you can get stricture, ischemia in the lateral portion that sets you up for a variety of complications, including stricture, marginal ulcers, bile reflux worsening, and things like that. So these are some of the common technical errors we see in surgeons who adopt the MGB and use variations on our preferred technique. The other thing I wanted to point out briefly before we get started, GE reflux is not just the MGB. So gastroesophageal disease is one of the most common disorders of the gastrointestinal tract, and 9.1 million visits annually in the United States, 4.4 million, the most common gastrointestinal discharge diagnosis in the United States. I mean, these are not all MGB patients. In addition, one of the most feared complications is esophageal cancer. And over the past few years, it's gone from 4 to 23 per 100,000 patients. That's an increase of 600%. And that, again, is not all MGB patients of mine. There is some study showing 20% of Western population have GE reflux. It's not just the MGB. 1 out of 5 people in this study, and with this time series gone from 1990 to up to in the recent years, you see that the rate has increased to almost 25% of Americans reporting they have reflux. Again, not just the MGB. GE reflux is present in probably a quarter of the people watching this right now. In fact, some of them are getting it as I talk. So we like to mention 3 topics that we'll ask the presenters to talk a little bit about. One is maybe you get GE reflux in a patient because the surgical procedure itself is flawed, so damaging that everyone or a large portion of those people receiving a surgical procedure are going to get reflux. Another type of reflux situation is where there's a surgeon or technical error that leads to reflux. Examples of that would be a stricture or ischemia. And then finally, post-op patients can have diet and lifestyle actions. So the vast majority of GE reflux is related to this topic. And so we have this mix we'd like to hear from the presenters today, and I'll look forward to them discussing this. Just briefly, a surgical procedure, what we mean by that is that reflux occurs in all, many, or most patients get reflux. The surgeon or technical areas results vary based on the surgeon and the technique. For example, good surgeons with a good technique have low reflux, and in contrast, surgeons who use maybe a different or flawed technique might have high reflux rates. And then finally, the post-op patient diet and lifestyle results match worldwide epidemic of GE reflux. And if that's the case, that is a diet and lifestyle, then we have some options to provide our post-op patients. And we may or may not talk about that today, but I certainly encourage us to look at that factor. The procedure. The surgical procedure can be a cause of reflux in all, many, or most patients. And the classic example of this is the Mason loop gastric bypass. And when I invented the MGB, everybody said, oh, it's just the Mason loop. And we now know that if you put a gastrojejunostomy adjacent to the esophagus, there's going to be all, many, or most patients have reflux. So one possibility we could talk about today, maybe the MGB is another Mason loop. We've been talking about that for 24 years now. I'm hoping one day we'll get past it. The second choice here is surgeon technical errors, and we won't talk too much about that. I have a full presentation on that if anyone's interested. But basically, if, for example, you notice here, this is the lesser curvature and pulled over, you can see when creating this pouch, this surgeon essentially created a 180-degree twist. You could imagine that the release of fluids, bile, if it refluxes into the stomach, all of that would be obstructed partially, at least, in such a twisted pouch in creating a gastrojejunostomy, especially if it was anterior, because it would maintain this 180-degree twist. So technical errors is the other question I think we would like to see our presenters discuss today. And here's another example where, depending on the stapling and the size of the pouch, we can see stricture, ischemia, foreign body effects, ulcer, gastritis, and bile reflux. Again, a technical error at the time of surgery, which might lead to variations in the reported outcomes from a, quote, single anastomosis, one anastomosis, or MGB. The final one, which I hope we'll talk about, but I wouldn't be surprised since we're surgeons, so we skip it, and that is what happens in the post-operative period. What do we recommend for diet and lifestyle for post-bariatric patients? And I'll talk about that just for a minute now, if I have permission. So what we know from the diet and lifestyle studies is a high-fat, low-fiber diet results in a high incidence or much higher incidence, up to 700% higher in rates of reported GERD. Here's a study looking at those things that cause a marked increase in GERD. And this is odds ratio. So this means that those who reported midnight snacking were almost 600% more likely to report midnight snacking. Midnight snacking led to a higher rate of GERD. Skipping breakfast 3 times higher, eating quickly, your phone's on, talking, watching TV, for example, almost 5 times higher, hot foods, eating beyond when you're full. This is a classic comment here. Fish or meat or eggs, high fat foods, less than 3 hours between dinner and bed, over 7 times higher, smoking, alcohol, and just being sad in general. Conversely, we know vegetarian diets decrease the risk to almost 30% less, and physical activity. So there are a lot of things that can be done. And this all really sounds like many of my post-op patients with GERD. Okay, so how do we stop reflux in cancer? Stop or prevent reflux, surgical technique, diet and lifestyle. But number one, from the post-op period, we're talking about eat less high-fat, high-protein foods. What can you do to cause or prevent cancer? Well, there's good research now that what you eat makes a difference on reflux and cancer. So antioxidants, for example, make a difference. In this study, the amount of antioxidants calculated from the diet decreased from the 100% or referral level down by half if you ate a higher rate, the highest quartile of antioxidant fresh fruits and vegetables in your daily food, cutting the cancer risk in half. On the other hand, in the same study, people taking vitamin pills like vitamin C or E, there was no reduction in risk. So the pills don't work, and that's a common finding for a lot of these studies. So taking extra antioxidant pills didn't work, but food that had these vitamins and minerals in it did work by decreasing the risk by 50%. The most protective effect was attributable to certain kinds of vegetables, so red, colorful orange vegetables, dark green leafy vegetables, berries, apples, and citrus, oranges, grapefruit, etc. So one of the things to remember when we get deep into talking about anatomy and surgery, there's one simple thing to do, which is to eat more fresh fruits and vegetables. And of course, eating more fresh fruits and vegetables means eating less fat and meat. And so you get more fiber and other nutrients. So simple again, just eat more fresh fruits and vegetables. And another study, consumption of non-vegetarian foods was an independent predictor of GERD. And another study, a vegetarian protective factor against reflux. Non-vegetarian participants had twice the rate of GERD in this study. And of course, then we know what to do. We'll just give antacids, PPIs. We now, around the world, spend $4 billion back in 2006, $4 billion a year on just Nexium alone. It's not just MGB patients who need Nexium. So it's not just GERD is a very common disease, and it's increasing. But vegetarian diets, characterized by greater consumption of fresh fruits and vegetables, innumerable phytochemicals, dietary fiber, antioxidants, this type of diet helps improve, lowers oxidative stress, reduces blood lipids, and is associated with reduced risk of other diseases, particularly cardiovascular disease, type 2 diabetes. And moreover, fatty meals decrease lower esophageal sphincter pressure, which aggravate or cause gastroesophageal reflux disease. So I'm putting in a little plug here before we start talking as surgeons to think about what we eat. So our summary, GERD, it can be the surgical procedure, the technique, and the post-op diet and lifestyle. So today's presentations, that's what we'll be talking about. I thank you all very much and look forward to the discussion later in the presentation. Thanks again.